What gives me most satisfaction in my work is the focus on endoscopy. Because if I focus on endoscopy, I automatically focus on the patient. Endoscopy is a very technology and innovation-driven field. So with this you can apply latest technology and latest innovations on a daily basis for the benefit of the patient. That is very fascinating to me. In our unit we do approximately 8,000 procedures per year, and a lot of these procedures are related to GI bleeding. In easy numbers, that means 1 or 2 patients are admitted through our emergency room every night with GI bleeding. And apart from that, we have a lot of people on intensive care unit that also are prone to bleeding. So we cover the whole spectrum of GI bleeding, and a lot of these GI bleedings are in difficult situations, patients on anticoagulants or severe bleeding, cancerous tissues. And based on that, we also use the whole spectrum of endoscopic tools to achieve hemostasis. We started to include hemostatic powders from the very early ages into our endoscopic toolbox. And from what we learned also across studies that we're doing with hemostatic powders, they're very easy to use. They offer the beauty that you don't need precise targeting. You can also use them in patients that are impaired in their coagulation status. You can use them in difficult anatomical situations, and also you can cover quite large surfaces along the GI tract with hemostatic powders. And as a latest addition, we included Nexpowder in 2021, so also we were the early adopters. Nexpowder has 3 major indications. The first broad indication is prophylaxis of bleeding after endoscopic resections. If you think about, for example, endoscopic resections of lateral spreading tumors in the right-sided colon, those are definitely resection planes where you want to treat or prevent the occurrence of post-resection bleeding. And of course you can use mechanical devices, but sometimes the resection plane is too large to be closed mechanically. And there it's ideal to cover those resection planes, for example, with Nexpowder to prevent rebleeding after resection. Second major indication is of course active bleeding. And active bleeding, if it's a 1B bleeding from vulnerable tissue, for example, a large cancerous surface, those are situations where I'm not very keen on using injection therapy or mechanical therapy, because you're induce damage to the mucosa even more and you can exaggerate bleeding. And there I think Nexpowder is ideal because you can cover large surfaces and at the same time it's a touch-free application. And thirdly, we want to prophylactically treat patients that had bleeding. Think about Forest 2A or 2B peptic ulcer disease. And if you look at the literature, we know that they have a certain risk of rebleeding. And those are ideal candidates, at least to me, to treat them prophylactically for rebleeding with Nexpowder. If I think about one of the last cases I did with Nexpowder, that was an 87-year-old male that was admitted to our hospital through the emergency room with tarry stool for 3 days. And he had 2 things. One, he had an impaired anticoagulation status due to the intake of oral anticoagulants. And secondly, he had a large gastric tumor. And when we scoped him the next day after admission, we saw that he had diffuse bleeding from the cancerous tissue. Not an ideal situation for injection therapy or mechanical therapy, but we were very effective in treating and preventing further bleeding with Nexpowder. And we were able to cover the quite large gastric tumor with Nexpowder. But it's not only about single cases. If we look at the literature, we clearly see that we have a very effective immediate hemostasis. Hemostatic rates for immediate hemostasis are way over 90%. And at the same time, very low rebleeding risk after application of Nexpowder, below 5%, maybe below 4%. So that tells me we have a very effective and safe hemostatic agent that we can use to achieve endoscopic hemostasis. The impact that Nexpowder has on the patient and also on the endoscopist is, at least to me, centered around its low pressure application. For the endoscopist, low pressure application means that you can maintain endoscopic view throughout the procedure. This is beautiful because you really can target the lesion and make sure that you reach the bleeding site. And low pressure application for the patient means, in one word, safe application. Because only if you have a low pressure application, you can be sure that even if the tissue is vulnerable due to a thin bowel wall or inflammation underlying, that it's still safe without risking intestinal perforations.